Okay. Good morning still, everyone. Okay, so everyone still awake? It's the last talk. I think it's quite a boring talk, chronic pain. When you hear of chronic pain, it's a very boring kind of topic. And role of RA in prevention of chronic pain, if you read a lot of articles, they just bring you round and round and round with no conclusion. But my first question is, has anyone seen chronic postoperative pain? Hands up. Has anyone seen? How many of you have seen? So little, right? So that's why I only been presenting one article, not a lot of articles, right? One article. But what is the definition of chronic postoperative pain? So it's chronic pain, develops or increasing intensity after a surgical procedure. There must be after a surgical procedure, and persists beyond the healing process. Means they must, after, let's say you have a mastectomy or inguinal hernia repair or incision section, if they have persistent pain, you make sure that all the tissue trauma has healed. Then you can label them as having chronic persistent post-surgical pain and not before, right? If a surgeon sends a case to you, to the clinic, saying that this guy has chronic persistent pain syndrome, you're going to make sure that all the tissue has no infection, there's no collection, okay? And usually it's after 3 months, all tissue has healed. Simple. Okay. So I've gone through this. I found this article is published in Anaesthesia in year 2021. The role of regional anesthesia and multimodal anesthesia in the prevention of chronic postoperative pain. This article I find is quite good because it leads you to a lot of studies that's been done, trying to link whether RA is beneficial in preventing chronic post-surgical pain syndrome. Okay. So what is the importance of chronic persistent post-surgical pain? It reduces quality of life and contributing to academic burden. It could serve as a substantial source of chronic pain generation. Means as our life improves, could be a source of chronic pain, okay? Persistent post-surgical pain. And elective surgery is something that allows us to investigate factors that may influence pain, as traumatic injury is not predictable. So patients come in for elective surgery, you want to do study, you divide them, you randomize, control them, and you have your intervention without intervention, see whether it helps in preventing chronic pain. And why is this topic so important, RA and chronic pain? Is this just another question trying to justify why we should do more regional anesthesia? Right? The first, Dr. Murphy is trying to, it saves costs. Right? Second, improves patient satisfaction. Now say, it improves chronic pain, that's why you must do RA. Are we trying to answer the question, why are we doing regional anesthesia? Does it help now, right? Correct? I mean, it improves costs, less costs, patient more satisfied, and does it improve outcome? And one of the outcome is, does it reduce the incidence of chronic pain? So the number of studies of impact of RA in the rate of chronic persistent pain has increased. You can see 2012 is only 23 studies. 2018 there are 40 studies, almost double, all right, within a span of 6 years. But again, there's varying conclusions because there's a lot, how you define the pain score is used as a criteria. So if you take a pain score, all right, some studies may take a pain score of less than 3 is not considered pain at all. Or some people take a less than pain score, more than 5 only you consider them as having pain. So if you take a higher pain score, of course, incidence will be lower. If you take a lower pain score, then the incidence will be higher. Am I right? Make sense to you? Yes? Because if you take a pain score 2, it's just mandibulitis. Don't care about them, right? They're not having pain at all. Pain score more than 5, there only is significant pain. Okay, and then there's a different type of surgeries, okay? Surgeries like hernia repair, the incidence may be around 10-20%. Surgeries like breast surgery may be higher, about 30%. And time point assessment, when you assess them, you assess it in 1 month, 2 months, 3 months, or 6 months. Sometimes by 6 months, some of the chronic pain would have subsided, no more pain really, okay? And this is a very important factor, the last one. True variation in extent of chronic post-operative pain between individuals. Human factor, the patient factor. It's very, very, very important. I'm letting you know. Where some patients who are anxious, they have depression, a lot of psychosocial issues. These are patients of high risk of getting chronic post-operative pain. Okay. those athletes who are fit, they're happy, they do yoga, they are very calm. These are patients that usually they don't get chronic postoperative pain. All right. So and like one of the factors that one of the strong predictors of chronic pain is severe acute post-operative pain after a surgery. If you have a lot of pain during after surgery, then your chances of getting chronic pain is very high. But severe acute post-operative pain, is it due to the patient factor or is it due to the doctor's factors? That we need to ask. Why some patients have more pain than the rest? So we as anesthetists, when we do our pre-operative round, we need to assess the patient thoroughly, not just medically, and talk to them, is try to see whether they have a lot of anxiety, whether they have depression, whether there's any worried, how about their psychosocial issues, are they worried about their children? Okay, so this is a very boring slide of how chronic pain may happen. So you can see here, surgery, you have nerve injury, tissue injury, change to the neural pathway, we have peripheral sensitization, central sensitization, unresolved pain. All right, to make it simple, so in this journal, so there are 3 types of pain: nociceptive pain, inflammatory pain, and neuropathic pain. So nociceptive pain is when the surgeon damages the tissue, you cut the tissue, right? Okay, surgical incision of nerve, right? You cut, definitely you have pain. You have pain receptor. And the evolutionary process, this is human. We have pain because there's damage. So this is adaptive. This is appropriate. When we have trauma, we have pain. All right, and usually it's reversible. When the tissue heals, it reverses. All right, and this process is peripheral sensitization. Okay, simple. Then when you cut, around the tissue will have inflammation, redness. Am I right? When you get an injury, around the tissue, even though there's no injury, you touch now, there's pain. Not at the wound, around the wound. Correct? So this is all due to the inflammation, all the cells coming in. So again, this is adaptive, all right? The body wants you to rest, to heal. And it's generally reversible also, all right? But now, there may be some central sensation, means your spinal cord and your brain may be sensitized now because of the inflammation, all right? There are a lot of inflammation mediators being released, and your brain and your spinal cord is involved as well. Now, neuropathic, this is when the surgeon cut the nerve. So this is maladaptive, and it causes neuropathic pain. It may be reversible or may not be reversible. If you have seen a lot of patients, some where you cut the nerve, some have no pain, but some may have pain, all right? Some you compress the nerve, some will have pain, and some will have no pain. Make sense to you? No. All right. So if you think of 2 surgeries, 2 incision, midline incision and a phalansteal incision for cesarean section, which one do you think risk of cutting nerves? Midline or phalansteal? Midline and phalansteal. Midline? Phalansteal? So you think that the midline has more pain, you got to cut more than 2. But if you look at the nerve supply of the anterior abdominal wall, the midline, there's not much nerve supply in the midline there. If you see, very small nerve. But you do a phalansteal and you really track it to the lateral part, you may hit which nerve will you hurt it there? Your ilioinguinal 2 nerves there. And that's why some people, they get persistent post-surgical pain after the cesarean section, all right? Okay, doesn't mean that one incision is okay, so again, this is maladaptive, when the nerve is being involved. All right, like you do a thoracotomy, if you're not careful when you put the retractor, you may compress on the intercostal nerve. Okay, they cause nerve damage. Okay, so again, it's very boring, right? You see, chronic pain. Again, this preoperatively, intraoperatively, postoperatively, and recover. Okay, so you see events again. Prepare the patient, surgical injury, acute pain, chronic pain. Okay? Again, biopsychosocial approach is important. And if you look at the surgical here, minimally invasive techniques, of course, is associated with a lower risk of chronic pain. Okay? Regional anesthesia, multimodal, and minimize opioid use. Okay, so how does the impact of RA in the chronic person? So there are a lot of entry point here. You can read here. Okay, perineal nerve sensitization, local information, central brain. But the thing that the RA can't really target is here. You see the behavioral issue, whether they're having depression, anxiety. This part RA will not be targeted. And that's why there will be a lot of variation in the study results. This part and this part also, our genetics. RA will not be able to target. All right? So if you go to this article, there's a lot of things here. Breast surgery, like I said, if you see here, paravertebral block and intravenous lidocaine is found to be very good. Okay, thoracotomy, epidural, and paravertebral block. Unfortunately, I think no ESP yet. There's still a lot of argument about ESP, whether it really works or not for thoracotomy. Cesarean section, if they can give a TAP block. Right, again, a lot here. If you go to this article, they'll give you a link to all these articles, and if you want to read, you can go through all of them. Okay. So again, not just RA. Always combine RA with other like ketamine, LA, gabapentinoids. This is your Sidex. This is your COX-2 and Panadol. And the future of multimodal anesthesia with RA and chronic persistent pain is, if you need to do a study, you need to determine when. When do you want to do the block? Before or after? All right. Who do you want to target? Do you want to target high-risk patient, or you want to target a heterogeneous group of patient where you're going to find no significant findings again? Okay. What surgery? Okay. And where to block? Larger RCTs. Of course, you try to select a high risk of patients, and always target the biopsychosocial model. So, in conclusion, do we do RA or do RA to provide chronic pain? So, for me personally, you assess the patient. If it's a high risk surgery for developing chronic pain, then I would do a regional block. Okay. If this is a high risk patient with a lot of anxiety, a lot of pain issues, chronic pain patients, high use of opioid, then I will use regional anesthesia strongly. In between, then it's up to you. All right, you got to do the assessment again. Right. So whether it really prevents chronic pain, like I said, you go to the studies now. Some yes, some no. But of course, it's a very heterogeneous kind of results, right? So again, I'll leave you with more questions than answer. Sorry. All right, that's all. Thank you.